Okay, so welcome to this edition of Journal Club. We're down at in Wall, New Jersey right now. Our next Journal Club is actually in 2 days at Trinitas Hospital, where we'll continue our journey through the journals. Anyone have interesting cases?
So, had a interesting case. Can be viewed as either pre-hospital or an ER case, but the patient was on LVAD. He's been an LVAD patient for a few months. Don't know if it was bridge or final, but presented to EMS, not feeling well. EMS found him to be in VFib. He had an internal defibrillator, which had given 5 shocks and was still in VFib. And so the best case is now what do we do from here?
Anyone?
Describe it, or?
So you have a patient with an LVAD. For those of you who don't know, LVAD is a left ventricular assist device. Essentially, it's doing most of the work for the heart. So if you find them, what did you find them in?
So we found him in VFib, both monomorph and VTAC as well, and polymorphic VTAC at one point.
So one of the things that everyone always says is, what does the patient look like?
Yeah.
Were they unconscious? Were they vomiting, diaphoretic, or were they just like, oh hey?
So the patient's mental status was interesting because he was conversational but slightly confused. So,
It's not the textbook case where they're lethargic.
Yeah. So you could converse with him, but he was, per the family that was with him, not at his normal mental status. So, yeah.
Yeah, so altered VFib or VTAC.
Right.
Was there a pulse?
So, sort of.
So for those of you who don't know, LVAD may or may not, most of the times they don't have a pulse, and sometimes they don't even have a blood pressure.
So we tried to get a blood pressure using the Doppler, and we were unable to. Even with the Doppler, there was really no pulsatile waveform that we could speak of. And obviously, you could auscultate the chest, you could hear the device working, the patient was talking to you. And there was a carotid pulse, but there was not a radial pulse of any kind.
So the question is there enough perfusion going through the body, or is there, obviously there's enough to keep him somewhat mentally aroused, but the question is, he's confused, so is this unstable or stable?
Right, so he's like right in the edge there between the two. So we looked at his device, he was heart rate 3 if I remember correctly. Batteries were great. RPMs were in the normal range of what I would expect, but the flow along was low flow. So very first thing we did was a fluid bolus. Dehydration is a common problem with these, and it was just, as we expected, it had no effect. We pressured back that in. We didn't really waste a lot of time with it, but nonetheless, we wanted to start with that. Right around that time, the rhythm switched from VFib to what looked very much like polymorphic VTAC. Gave 2 grams of mag to no effect. We used to give a lidocaine bolus and drip to no effect. And at that point, started debating sedation, no sedation, or do we just proceed with synchronized cardioversion, defibrillation, et cetera, et cetera. So.
These patients get everybody kind of amped up when they come in, especially when no blood pressure is being found, or somebody can't find a pulse. It's only continuous flow, so you don't get the pulsatile waveform. So almost all the time you don't feel a pulse anywhere you go, whether it be the radials, even the carotids, you don't really feel any pulsatile source for finding a pulse. The best thing to do, when these patients come in, like we were talking about earlier, is just to throw fluids at them right away, because you get a lot of suction arrhythmias with LVADs. So any kind of volume depletion in these patients, whether they be sick diarrhea, vomiting, or out in the heat and decreased fluid intake. Just a suction of the LVAD device itself can throw them into arrhythmia. So starting somebody on fluids right away is like a great option. The electrolytes in these patients, they're like heart failure patients, so the electrolytes are another big thing to jump on right away. You want their potassium kind of in the higher range. You definitely want to throw MAG at them, if you see, like the...
I neglected to mention, the patient was also a dialysis patient.
Very complex cases all the time.
Well, you do have a lot of cardiorenal,
Yep.
hepatorenal cases.
He was due for dialysis in about 6 hours from when he presented to the ER. Yeah. So if anything, we were expecting hyperkalemia.
But you can always shock these patients, right? So you have the LVAD in place. It's like a big jet engine. It's doing all the perfusion for the heart. The heart's not really doing any squeeze. These patients are on a bridge to transplant. They're at the very end of the spectrum, or it's just a destination device. So you can always shock these patients and try to get their arrhythmia back. But really what you want to do is just look at mentation in these patients a lot of time. If they're mentating fine, they can be in persistent VTAC even for a while. After trying fluid and stuff, but then there's no hesitation to really shock this patient. You're not going to throw off the LVAD in any way or stop it from working.
A lot of these guys will suffer from hemolysis,
Yeah.
or they'll even just be in persistent VF. They'll come to the clinic visit and they'll be like, "Oh, you're in VF. We'll just shock you right now, put it back into a rhythm, send them home." So it's not something to freak out about. And actually, I think one of the things that came up a couple years ago on the national scene was, what do you do if these guys come in cardiac arrest?
Yeah, CPR, no CPR, I guess is the big question.
And I think it's still controversial. I think it's still, people are there's not one answer. I would just start CPR if they need it, but just treat them like a regular patient, because if they're in cardiac arrest, they're in cardiac arrest.
Kind of in-game.
Yeah.
If you guys have been responding as physicians, I was just wondering, do you guys have in your responders like an iStat or point of care, like electrolytes?
So we carry that in the past. The problem is temperature control, keeping the cartridges at the proper temperature, and then calibration. So while we have it, we really have not been using it. And then there's a couple of companies that have point of care testing for like troponin and things like that. How much is it really going to make a difference pre-hospitally? I'm not sure. So.
Can't be cheap either, right?
Oh, they're very expensive.
Associated with vibration and temperature in terms of using them in the back of the ambulance while you're moving, that kind of thing. So in this particular case, patient did anterior posterior replacement of pads and gave him some ketamine and synchronized cardioversion of 200 joules, and worked like a charm. So other than the fluid bolus initially, because of your concerns with LVADs,
The most common thing is a pump failure, where it's low flow.
I think that's, blow some fluids in there as quickly as possible as a first step, and almost every LVAD problem is a great place to start.
Yeah.
And then after that, you almost ignore the fact that it's an LVAD,
Yeah.
and treat it like,
Well, you went down the line of unstable because he was confused, VTAC.
we kind of treated him like a stable almost, because we started with meds first. And frankly, it was a judgment call. Myself and one of the other physicians that was present, we were really going back and forth, and we decided that we had some time.
When he's conversing too, but the family's telling you that he's not himself. So
Right. Yeah, and every case is going to be a little different, and it's hard to describe specifically, but he was pretty conversant. And we were able to have a conversation about the events that had just occurred just a few minutes before. So.
Yeah, pre-hospitally, we have it easy because we're like, let's transport.
So I think the original issue was that the EMS crew really wasn't sure how to proceed, and I think the guidance, as
And
I
that's
just said, is fluid bolus and then do what you always do. Treat
Another
it
thing,
like you see.
I think it was the HeartMate 2, not the 3, but some of them came with like a manual pump. These are people that, as your rescue squad, as your first aid, or even if you're in an ALS system that has control over your direct response area, you can actually put a flag on these houses, and then so responders know, like, hey, there's an LVAD here. And then because of that, within the community, you can have someone come out and actually do an LVAD class where, okay, basically what we went over right now is what do you do if, and kind of just go down the line. A lot of the times, if you are in a situation like this, the family is the best point of contact, the best person to kind of give you information, because they're the ones who the hospital has trained. The hospital, they know the patients, they know kind of what's needed, what's not needed, what's normal, what's not normal. So for this patient, even though they're conversing with you, you went to talk to the family and they're just like, no, he's confused. Like sometimes for me, I'm just like, he seems okay, but if you're saying that he's not acting normally, this is their family who sees them every day, that kind of makes a difference.
Plus the family knows where the extra battery packs are, which is.
Oh, that's the other thing.
The LVAD.
So sometimes that's a big thing. I already forgot about it, but make sure that you grab the extra battery. Make sure that you grab the charger too.
That's right.
So, because like I'm fortunate that one of the places I work has a charger, but my other sites don't have a charger. So we're either transporting this patient as soon as possible, or we can't. It's not something that you can just plug into the wall. It doesn't take a standard outlet.
Big battery packs.
The other big thing that happens a lot is drive-line infections. So it's kind of taking a look at it, and it's just like any other infection. You'll see cellulitis, you'll see swelling, they'll report fevers, things like that. Again, you have your standard pneumonia, UTI, things like that. But the drive-line infections are kind of the worst, because sometimes you might have to switch out the equipment, which, if it's pumping most of your blood volume, it's sort of a big deal. Any other interesting cases? I know we have a couple for probably, we'll probably go over on Thursday, some of the other cases. You want to get into some of the articles?
Yeah, no problem.
Which articles do you want to do?
I can do mine. Sure. I actually have two. Why don't I do the pediatric out of hospital traumatic CPR, cardiac arrest one? So that's the, I think,
Yeah.
1, 2, 3, 4, 6 article from the top. So basically, this article talks about the pediatric traumatic cardiac arrest and in out of hospital setting, and then they also talks about the criteria for the TRE for these patients. So the American College of Surgeons Committee on Trauma has the guideline for the TRE, termination of resuscitative effort, for adult victims of traumatic cardiac arrest. And in that guideline, they say that the TRE may be considered when there is no ROSC, despite of the appropriate field EMS treatment with minimally interrupted CPR for specific interval, which is up to 15 minutes usually. And then this criteria, TRE criteria is actually validated in adult victim with blunt traumatic cardiac arrest in out-of-hospital setting, but not in the pediatric populations. And then, so we don't know how well this criteria does we don't really know how well this criteria perform in the pediatric populations. So this article, the authors looked into see the characteristics and the outcomes of the pediatric traumatic cardiac arrest in out-of-hospital setting, and they also validated this criteria to these pediatric cohorts. So this study was done in Japan, actually, and then they analyzed the data from the data of the pediatric patient who were involved in a traffic accident. And then the study period was in like 5 years. So they included pediatric patients, and then pediatric patients are defined as somebody 18 years or younger. And then they included the victims of traffic accidents, including the occupants of the motor vehicle and motorbike riders, bicyclists, and the pedestrians. And then one thing to note is that they did not include other types of trauma, such as a fall victim or penetrating injury or like a victim of abuse. And then they basically, their primary outcome was the 1 month neurological outcome after the cardiac arrest, and the secondary outcome was 1 month survival after the cardiac arrest. during this study period, they had 8,786 victims, a pediatric out-of-hospital cardiac arrest, and then 500, little less than 600 victims met the inclusion criteria. And then after exclusion, they included 582 patients for the analysis. So characteristics of those victims, median age was 16 years, and then 73% were boys. And then median duration of out-of-hospital CPR was 23 minutes. And then of those patients, so of those 582 patients, 8 patients, which is 1.4% of the studied patients, had 1 month favorable neurologic outcomes. And then 20 patients, which is 3.4%, had a 1 month survival. So in terms when compared survivors versus non-survivor, survivors are significantly younger than those who died, 8 years versus 16 years. And the survivors had significantly shorter out-of-hospital CPR time, which was 9 minutes versus 23 minutes. And then those who survived had a higher rate of out-of-hospital ROSC, which is 70% versus 8%. And then when compared patients with favorable neurological outcomes with those with unfavorable neurological outcomes, all patients with favorable neuro outcomes had out-of-hospital ROSC. And then those who had favorable neurological outcomes had significantly shorter duration of out-of-hospital CPR, which was 4 minutes versus 23 minutes. And interestingly, so after 2 minutes of the out-of-hospital CPR, the rate of 1 month favorable neurological outcomes diminished to less than 1%. And after 30 minutes of out-of-hospital CPR, the rate of 1 month of favorable neurological outcomes basically dropped down to zero. And then after 15 minutes of the out-of-hospital CPR, the chance of survival diminished down to less than 1%. And then when the TRA criteria that I mentioned earlier, the adult TRA criteria, which is cardiac arrest on the scene and then unsuccessful resuscitation after the greater than 15 minutes of CPR is applied to those pediatric cohort, the criteria actually had a 74% sensitivity and 100% specificity, and then positive predictive value of 1 in predicting unfavorable neurological outcomes. And then the criteria had a 75% sensitivity and specificity and 0.99 positive predictive value detecting the mortality in the pediatric populations. So in these studies, I mean, there are some limitations. They only included the patient trauma victims with non-trauma or traffic accident. And then this was basically done in Japan. And then the medics in Japan are somewhat different from here. They cannot do like a below decompression, so they are not really used to the integration of those kind of procedures actually. And then also, I think the biggest issue is that they did not mention anything about the specific injury that these victims had. So if the patient had a brain injury, it directly affect the 1 month neurological outcomes. But they didn't mention if the patient had what kind of injury they had. So I think it's one of the big limitation to this study. But overall, I mean, if you were to consider the TRE in those pediatric patients with traumatic cardiac arrest, if you work more than 15 minutes, and if you did all the best you can, and then if you did not get ROSC after the 15 minutes, it may be beneficial for you to know that there's a data saying that these patients has really low chance of
Survival.
outcome or survival or good outcome.
So I know I've talked to a couple of you about this several times before, that pediatric termination, TRE's termination or resuscitative effort is very difficult. A lot of times it may be in a public place, it may be in front of family, and it may even be in a school or in a pool, and these are very difficult times. Pediatric cardiac arrest, especially traumatic, a lot of the times it's going to be car accidents. So do you really pronounce someone on the scene? It makes it difficult sometimes, but when you're transporting in the back of an ambulance, driving God knows how fast, lights and sirens, if the possibility of a good outcome is 0%, because you've been working it for over 15 minutes. You know, do you want to endanger the lives of not only responders but of bystanders in traffic? I know recently there was an accident where 2 ambulances actually hit each other responding to a call. Luckily, there was no patients in the ambulance, but you know, there's been plenty of cases where, you know, a patient, you know, just had some sort of event, they're being transported to the hospital, and then they get involved in an accident. So where are their injuries from? Are there injuries from the first accident or the second accident? Who knows? And these are things that we have to keep in mind. I know that's one of the most, I would say the second most dangerous place is taking a patient to the hospital. You know, does it need to be lights and sirens? I don't know. It's different in every case, but you know, it poses a danger. Based on this information, would you stay on scene longer? You know, because the favorable outcomes, most of them were with Ross on scene. So if you're not getting Ross on scene, you know, you're doing a detriment. And we all know that when we move a patient, we can't do good quality CPR. So, but also if this is a true trauma, should we be doing CPR at all?
That's the question.
You know, clear the box, make sure it's not a pneumothorax, make sure there's no pericardial fusion, and move on. You know, is it hemorrhage? Is it something? What's causing this? Because a lot of times it's not, the heart is not beating, especially for traumatic arrest. For a medical arrest, it's a different story. A lot of the times in peds, we're thinking respiratory. So doing CPR in that case is much more beneficial. But it's definitely more beneficial than just scoop and run. So, any other comments with that? Does this change your practice?
It doesn't change mine. I think it's tough, especially in the pediatric world, if you just give yourself a set of rules to say, oh, I'm going to terminate resuscitative efforts in this patient because after 15 minutes, it's a slim chance. It's very tough. Like on scene, families are going hysterical, especially, I mean, this is completely unexpected events in a large population of people that have no comorbid medical problems. It's unlike the adult population nowadays.
Sometimes they're expecting it versus with a
Yeah.
child, a lot of the times it's out of nowhere.
Yeah. So I think, you know, TRE, somebody like on site, that would be very difficult. For me, even knowing there's a, you know, slim chance of anything, I think I would, you know.
I mean, you also have to
be more
consider
active.
the safety aspect to you yourself. You have a lot of
And your
hysterical
crew.
family members around. If you were to TRE a pediatric patient, we don't exactly know how the family's going to respond. And that's something that also to consider is that the safety of yourself and everyone else around you it's probably just better to continue resuscitative efforts to the hospital and then from there call it.
Yeah, it's tough
The-
unless there's obvious signs like
Yeah.
somebody's decapitated, there's decomposition. or
Brain
something.
matter.
This is like-
Brain matter.
this is very-
But remember, a lot of times kids, especially the younger pediatric group, they have the best chance, even after hypoxic brain injury, of bouncing
Yeah, I
back.
think even this paper showed it, less than 8 years old or around 8 years old have better survivability than the patients slightly older in the teenage years. This paper commented on that as well. So
When you decide to TRE, do you decide that, and you make that decision, when you do decide to TRE, are you bringing the parents in, or the family member, or the one that's the mother or the father inside the ambulance on the way to the location, I mean, on the way to the hospital, and then just having that conversation with them then, and then TRE? Or do
I
you
think
keep
well, the TRE in the back of a, you know, in the back of a rig is different because then, you know, everybody kind of stands back. But you're still transporting the patient. Leaving somebody on scene, now you got to get the medical examiner involved before you can clear the scene. So it's tough in a public place. So I guess if you were going to do it, it'd be more beneficial or easier in the back of the rig.
Right.
Once you have the doors closed and the wheels are turning. You know, because it's not a true pronouncement time. That happens at the, you know, the destination hospital, the doctors there pronounce.
And one of the things also is, especially with pronouncements, we don't really want to pronounce someone in a move-in ambulance, because then where did they actually get pronounced? So that's why we do a TRE protocol where we will move the patient to where they need to go. Now, would you change your protocols? You're running a big EMS system. Are you going to change your protocols to include TRE for pediatrics, or?
think it's tough.
It's just a
Call.
tough question,
It's
yeah.
really tough.
It depends on the environment as well,
Yeah.
one of the places where TRE actually started was in wilderness medicine. You're 45 minutes from the nearest station, let alone civilization. You have a cardiac arrest, what do you do? Do you do one round and then see what's going to go on, or do you just go till exhaustion and then possibly endanger yourself and the rest of the group, trying to revive someone who, just being out in the middle of nowhere, your chances of survival are drastically reduced.
I mean, we could apply the same concept to all these rural areas where transport time is, 30, 45 an hour at minimum.
Mhm.
So if you arrive at the scene and they've already been dead for who knows how long, I think that's,
It's something.
there I would probably incorporate a TRE. It's a little easier, I mean, it's a little difficult kind of practice in the area that we practice where we have so many different hospitals around us that it's just easy to transport the patient there and then have the ED doctor decide from there. I mean, but unless they've obviously shown signs of being gone for so long, they're already stiff, their jaw has a lot of trismus, kind of
Signs of death.
Yeah, like signs of death.
Yeah, it's very difficult.
Coming back to the question that I asked, so you have a child, it's out in the environment, cardiac arrest, it's been worked on for 20 or 30 minutes. You're already going with the decision to TRE, right? But you're in your mindset, you're always like, all right, let me just, or the medics call in and you're like, okay, you can call the TRE. The idea is bring them in the ambulance and then let the family know on the way to the destination hospital. But then you also have to keep in mind that discussion should occur already outside with the family member, because imagine bringing them in, telling them on the way there, like, okay, we're not, we're ending resuscitation, we're bringing them to the destination hospital. Now you're in a closed back of an ambulance, and let's say it's the father or the mother, and they start getting very aggressive, for safety, they should be aware of that coming in, so that they, don't get the surprise and then start acting up.
So one of the things that I always do is, especially with my patients, is, as we're working the arrest, there's always a point where, like, after the second round, you learn about comorbidities, downtime, things like that. You think about, okay, you start asking around, like, is there anything anyone else can think of? Is there a fistula? Maybe this is like hyperkalemic cardiac arrest. We can push calcium for it. Usually the hypoxia thing doesn't really happen for us because the first thing we do is start bagging them, start giving them oxygen. We just take that off the plate. People talk about getting glucose. For glucose to cause a cardiac arrest, they've been hypoglycemic for a freaking long time. And several people have commented, like, how accurate is like a finger stick in a cardiac arrest? If you really think that the patient was hypoglycemic, just give them dextrose and move on. Just take it off your list. We always talk about the H's and T's and kind of break down that list. But after that, there comes a point where, is this futile? At that point, I tell the team, like, listen, I'm going to talk to the family, continue the resuscitation. I invite the family to come and see the patient. And the big thing is you can't really sugarcoat it. Even before this happens, you tell them, like, listen, right now your loved one doesn't have a pulse. They've died, and we're trying to bring them back. A lot of people are under the aura of, oh, you know what, we're just doing CPR. It's like, no, they died. When you kind of like skirt around the topic, it doesn't sink in. They're like, oh, they're fine. They're just gonna wake up. It's like, no, they're not. And you kind of have to bring it like, listen, right now, the heart's not beating. We are beating the heart for them. Yeah.
I don't think there's any way to like let a family know about TRE, like you were saying. You can have that conversation and let them know,
Like ease into it.
It's a lot different when their eyes see everybody sit back and stop. You know what I mean? So-
But that's also why I give everyone's a head up. Like, listen, I'm going to bring the family in. I'm going to invite them in to see what we're doing. And then at that point, I announce, I'm bringing the family in, okay, when's the next pulse check? And I tell them, like, we're going to take a look at the heart with the ultrasound machine. If there may be, if there's no contractility, if the heart's not beating on its own, we're just going to pronounce. And I feel like that's made things much easier for the families as well, because they see that you're doing everything and it's just not working. That it's not when I pronounce the patient at that time, that's the time that they're going to die. Like, they've already died. We've just been trying to bring them back and it's not working.
Yeah.
And it's actually very difficult over the phone because, a lot of our paramedics are there by themselves, and it's difficult to kind of convey the scene to you. I'll usually even ask, like, it seems like it's medically futile right now. Is the family ready? Let's talk to the family, make sure they're ready for the pronouncement, and then we can call it once the family has tried. But it's very, very difficult. Like, this is probably the hardest thing that we have to do as emergency physicians, as EMS providers, or just anywhere. Even a 98-year-old or a 102-year-old who you would think that, everyone would be ready for this, they're not. They think that, they've outlived some of their children, and yet people think they're going to live forever, and it's difficult. And what are the 5 things that for good resuscitation? Witness arrest, initial rhythm, initial shockable rhythm,
Bystanders.
Good bystanders.
good what else? Good CO2 level. Like, these are the things that kind of tell you, hey, this person has a shot. And we're still learning more about cardiac arrest even today. And that's why, like, we're doing the TEEs, because we find that, depending on where you compress on the chest, you might not really be giving good quality CPR because the heart moves. Like, you guys see in the emergency room when we get a chest x-ray, heart's always in a different freaking place. So how can putting it smack in the middle really gonna hit the heart every single time? So. Next article.
Which one do you want to talk about? I have the CRASH 2 meta-analysis, so that's really quick, I think.
Sure.
So CRASH 2 came out a while ago. It showed it was TXA given to patients showed decreased mortality with no incidence of thrombosis anywhere in patients. So since then, the systemic review came out. It's mortality and thrombosis in injured adults receiving TXA, tranexamic acid, in the post-CRASH 2 era. So they did a systemic search from PubMed, Embase, Micromedics, and clinicaltrials.gov, and they did a meta-analysis on everything. They looked at 28 and 30-day mortality, and then they looked at in-hospital thrombotic events here. So they came up with a number of papers. The big thing in this meta-analysis was that TXA dosing wasn't standardized in all the trials. A lot of them were, retrospective OBS reviews or just observational studies. There's, I think, only one real RCT in the mix here. The other thing was the duration of how the TXA was given. Was it just given as a bolus of the 1 gram, or did it have the second maintenance dose as in the CRASH 2 trial, which was 1 gram over 8 hours? So CRASH 2, they did 1 gram in 10 minutes, followed by another gram over 8 hours. So these were, not consistent at the dose, or if there was a maintenance after the initial bolus, and at what time frame the patients received the TXA. So we know that in the first 1 hour is the greatest benefit from TXA. It extends out to 3 hours, with everything after 3 hours they're not really beneficial to the patient, and it can even cause some harm. What they did show at the end of their systemic review was a decrease in mortality, or lower incidence of mortality at both 28 and 30 days on traumatic patients receiving TXA, but they showed an increase in hospital thrombotic events. So this is, different than the CRASH 2 trial in that way. So they go on and talk about like why this may be, and that's, like the timing of the dosing. It wasn't a standardized dose these patients were getting. So does that matter? There's no way to really tell because a lot of this stuff was retrospective. Just more randomized control trials need to come out to look at this. Does it change the way that I'm going to practice? No, not at all. I think I'm a very big fan of TXA in bleeding patients, whether it be traumatic or non-traumatic. Everything from epistaxis, pregnant patients, hemorrhagic patients, and definitely trauma. I continue to use it. I do the 1 gram push, not necessarily always over 10 minutes when I'm working in the ED. And then usually whoever I'm handing off the patient to, once they're stabilized, I let them make the decision on if they want to do the bolus TXA or not. We have that discussion as kind of physician to physician. But this is just a systemic review, and that part kind of went against the CRASH 2 trial was the in-hospital thrombotic events.
Yeah, the whole thing with TXA is like it shows benefit if you give it within 3 hours.
Mm-hmm.
When in a hospital are you ever going to be able to give something within 3 hours? Like, never. So of course, like, in hospital medicine, it's not going to help. But if we don't give it pre-hospitally, you're never going to have the chance to continue it in the hospital. And that's why, it shows benefit. The research is still out there on what's, why. And we'll go from there.
Yeah, I think it's kind of changed my practice at all. In hospital thrombotic events.
One of the big things is it's TXA is really cheap, so you don't have someone pushing behind it to be like, hey, why don't you use more TXA? Because it's pennies on the dollar. And even people who use it all the time don't know like you can use it for other things. So we'll nebulize it for nosebleeds. Works pretty well. There was a recent study where they compared TXA Sopligits versus Pack-In, and they found that it's basically the same, which is better because now you don't have to freaking pack in there. Like it's horrific how much stuff they put in that you can fit in that nose.
Yeah.
Like I feel uncomfortable. So.
It's one of those wonder drugs that are going to come out for, and this can be used for everything. I mean, they used it in the past for like heart surgery, GI surgery, and now we're just trying to get to the bottom. And we're applying it in trauma, and then soon there's like studies for brain use, epistaxis, for everything.
Mm-hmm.
It's used commonly for vaginal bleeding as a take-home pill. So.
Yeah.
What's crazy to me though is that it's an old drug.
Yeah.
It's a very old drug. That's why it's, I guess, got some renewed appeal. Because it's part of what makes it so inexpensive. I mean, if TXA was a brand new medication, this would be some incredibly expensive, whatever, because of the way that.
There would be banners.
Right.
It would be advertisements on the radio.
So, this is sort of, unfortunately I'm not up enough on the history of it, but this is at least round 2 for TXA's popularity.
Yep.
So.
One more article, maybe 2.
Sure, I'll talk about the outcomes of pre-hospital chemical sedation with ketamine versus Haldol and benzo, or physical restraint only. This was a good article. I think I read it once before, and then I'm reading it again for Journal Club. And I know it was just around the time when ketamine started getting hot for agitation for patients in the ER. It's published in Pre-Hospital Emergency Care from authors from the Department of Emergency Medicine at Boston Medical Center, University of Massachusetts Medical School. Basically, their question was to describe the complications and outcomes of pre-hospital ketamine use for agitation as compared to other methods of physical or chemical restraint such as Haldol plus benzo or physical restraint only. The results showed that there were lower intubation rates in patients administered ketamine than prior literature, but compared to prior literatures, but their rate was still higher. And then high frequency of the intubation and the greater need for additional chemical restraint when compared to other restraint modalities. It was a single center retrospective review from a large urban academic center. The subjects were treated between January 2014 and February of 2018. For this EMS system, in November 2014, IM Haldol and benzo became available to the paramedics. And in November 2016, IM ketamine was added. So they had inclusion criteria of consecutive subject patients 18 years or older that were transported to the hospital by the EMS provider and that were administered any standing order intervention for combative or agitated behavior. The restraints were either handcuffs supplied with assistance from law enforcement or chemical restraints. So ketamine 4 milligrams per kilogram IM, estimated weight, Haldol 5 milligrams IM, and the benzo was either Versed or Ativan with a dose between 2 and 4 milligrams. Their exclusion criteria were those meds that we talked about above that were used for intubation induction, analgesia, anxiolytis. And then in certain physical restraints was the exclusion for physical restraints was those that were applied for a matter of protocol for non-combative patients in police custody. So whenever they get arrested, they're handcuffed. Also, the hospital-based service was the only service with standing orders for ketamine transporting patients to the study site. So that it had to be patients that were transported to that hospital. The outcomes were intubation rate, the need for additional physical or chemical restraint, emergency department length of stay, the need for a hospital admission, and then any employee injury. Results showed that there were 214 subjects that were included, 95 patients received ketamine, 68 received Haldol and benzo, and then 51 were physically restrained. As far as the patient characteristics in Table 1, the ketamine cohort was slightly younger compared to the physical restraint cohort. The mean age was 34 versus 42. There were fewer comorbidities in the ketamine group compared to the Haldol and benzo. Higher incidence of cocaine and opioid ingestion compared to physical restraints cohort. So if you look at it, it's like 14 versus 16 and 0 versus 3.9%. And then interestingly, there were 19 patients with 2 visits in the study group and then 1 with 3 visits. As far as the intubation rate, which is the one that kind of opens up our eyes, it looked like the ketamine group were more likely to be intubated compared to the Haldol and benzo. So it was like 11.6% compared to 1.5% with an odds ratio of 8. And then 6 out of the 11 intubation cases, which was 54%, were performed by one particular ED provider. Additional chemical restraints in the ketamine group was 49 compared to 25% in the benzo versus Haldol. And the length of stay in the ED was approximately 9.45 hours versus physical restraints was 6 hours. So there's a difference there with physical restraints versus those with Haldol and benzo, which was 9.4 hours. Adverse effects, as we know, with ketamine for those that were intubated were hypersalivation, laryngospasm, and then for those not intubated, 2 had emergent reactions, 1 hypersalivation and 1 laryngospasm. So there was a trend for ketamine intubation to have documented co-ingestions and to present around that overnight shift time. And then that one particular provider was the one that was working overnight that had the 50% of the intubation group intubated.
So maybe a little biased.
Yeah, definitely.
I also wondered when I was looking through here, and maybe they addressed it and I just skimmed over it. I read this a while ago, but did they give ketamine to the more sicker patients, perhaps, more the more agitated patients, or even the patients that they see more frequently? Or because most of us, we grew up on, just give Haldol Ativan, or Haldol Ativan Benadryl, or depending on what you had, just Ativan or Versed, But, now people are using ketamine. You know, are we just using it on the sicker patients, and that's why we're having these different results? You know, a true randomized trial would be, all right, you know, it doesn't matter what day, let's shuffle some cards, and if it's the card's red, you get ketamine. If the card's black, you get, you know, Haldol and Ativan, and then go from there. But I've also found that with some of the overdoses that we've been having lately, especially with the mixed batch of whatever they're taking or whatever synthetics they're on, I've had to give multiple doses of things. I've had to not only sedate them with a short-acting such as ketamine, but then also follow up with a long-acting, because we're able to control them, and at least, you know, maybe we can get our labs done, get a head CT for the altered mental status, or more importantly, for pre-hospitally, safely get to the hospital. I know that there was a recent case where there was an EMT who was stabbed in the back of the ambulance on the way to the hospital. Like, I like to winter wrap my patients. Does everyone know what a winter wrap is? Essentially, it's you put a flat sheet, then you put a blanket, and then you put the patient in, and then you wrap them up like a burrito, and then you buckle them in. And first of all, I feel like if I was wrapped up like a burrito, I would be very happy and very calm. It's like the gravity blanket, and that could be a good study right there. It's like burrito versus no burrito. Who is a more calmer patient?
Yeah, and to what you mentioned during the ketamine group, kind of like after when he got instituted, they found that there were like 27 times or cases when ketamine could have been applied, but Haldol and benzo was given. So it's kind of like, was there a reason why? Were they sick or not sick, or more agitated than not, younger or older, and stuff like that?
A lot of time it might be just provider comfort.
Yeah, definitely.
Not necessarily the patient, but the provider. That's why using the card system where, we have a red card today. Or even, you can do it for today. All even days get ketamine, all odd days get, other therapy. Or you want to have some sort of control group. And I don't know which one's better. I like to teach all my providers how to use everything, because one of the things that's been coming up is drug shortages. Rampant. And actually, you probably only know about half the drug shortages, because we get notifications that, hey, we're on our last crate for the entire eastern seaboard. We might not be getting a refill. And they let me know, but most people don't know until that crate's gone, and they're just like, okay, now we need you to not use this drug unless absolutely necessary. And these are happening daily. There is, I forget the website name right now, but anyone can Google it, like drug shortages or .com or something, and they actually have a running list of basics that are like, we ran out of saline for a while. Like really? So having a armamentarium that we can use in the event that we lose what we usually use, and that's also applies to airways. I'm usually, if I love to use the video, what happens when my video breaks? What happens when I run out of batteries? What happens when there's copious amount of secretions? You have to have a backup, and you have to be comfortable with it. What were you talking about again?
Ketamine versus benzo and Haldol. I'm on the same mentality. It depends on a couple of factors. Obviously, in the hospital, I have access to crew to help me out. But in the setting of outpatient pre-hospital, it's kind of like, how agitated are they? How fast do we have to take them down? How sick could they be? And other stuff to consider.
Yeah, and ketamine is kind of, they're researching ketamine as a therapy for everything nowadays. So depression, suicidality. Yeah. So you're treating multiple things at the same time. So yeah, my biggest thing, especially being a medical director, is keeping my staff safe. Yes, we're taking care of patients, but you want to go home to your family. So if this drug is gonna sedate the patient quickly, safely, you're not going to get a needle stick, you're not going to have all these other problems. You can at least secure them, make sure there's not a life-threatening injury happening or organic disease that may be masking with this behavior, because you don't know. Sometimes it's a subdural, sometimes it's hypoglycemia, but you don't know until you test their blood glucose. You don't know until you scan their head. You don't know until the family is like, oh, that's Uncle Ernie. He's always like this. It's about that time. And then you're like, okay, I feel better. I still need him to not be swinging and attacking my people, but now I'm not concerned that it's, a subdural or a bleed or something else that is, more importantly, is something that's reversible, something that I can actually change someone's outcome.
And even for the patient that you commonly see, because in this case it was like 19 patients that were in the study twice. Some patients, like you mentioned, and some of them even requested, oh yeah, I want the Haldol and benzo, or they say.
Or my favorite, I was at a festival, and the guy is being held down by 6 linebacker police officers. And they're struggling to hold him down, and he's just screaming, "I'm allergic to Haldol." And I'm like, I'm not giving you Haldol, but even if I was, I would still give it to you and just intubate you.
Or the ones that use commonly drugs, if they receive, special day, that they'll ask for it sometimes because they know they can get that weird trip up and everything.
No, I agree. I like ketamine in the pre-hospital setting just because it's one vial drop. I think Haldol precipitates with a lot of stuff. I think so. You got to drop 2 vials a lot of times, but yeah, ketamine. I think you can slam it and then everybody's a little bit more comfortable.
All right. You want to try one more article? I'm trying to clear this list. We got backlogs.
I'll do the one last tourniquet one. This should be a quick one.
Okay.
Since we know the outcomes are going to be poor. So this article came about because of obviously a lot of shootings, a lot of hemorrhage from extremities. I think they cited that overall 29% of mortality is due to hemorrhage from an extremity in the civilian world. And a lot of the civilian world and what we end up doing comes from the military. So military uses a windlass tourniquet. So as a result, that's what they actually studied for here. And the reason they study this is because oftentimes in mass casualty shootings or stabbings, EMS response is delayed because obviously first is scene safety, making sure that the scene is safe for anyone to go in. So a lot of times what ends up happening is that the civilian is the one who's the first person on the scene and who needs to take care of this. Now naturally, everyone's seen movies, so they think a belt's going to work and it's not. So this is why training with the tourniquets is important, but they're emphasizing is whether the untrained person, whether they can effectively place a tourniquet to actually stop a bleed. So this is a prospective randomized study. They used students in a university. There was 150 students that were assigned, they were all assigned equally to 3 different types of tourniquets. So it's the SAM XT, the CAT tourniquet, and the soft T. Volunteers complete a questionnaire before to determine their knowledge and prior experience and if they feel comfortable doing it. There were people that had prior experience for this, and then they also did study them as well. So they had this scenario where they had a leg injury that was bleeding, and without any intervention, it was going to bleed out in 2 minutes. They had 1 minute to read the manufacturer instructions for each one, and then from there, they were told by an instructor where to place the tourniquet. So this is to basically isolate the application process itself, and not so much having the knowledge of where to put it. So the attempts that were deemed stable were the ones that they stopped bleeding within 2 minutes, and then that weren't stable, they were considered a non-survivor. There was only 1 attempt allowed per participant. So 150 people were enrolled. They had 55 for the Sam XT, 46 for the CAT, and 49 for the Softy, respectively. Bleeding was successfully stopped in only a minority of, in only a small amount. So for the Sam XT, only 61%, CAT 72%, and the Softy 65%. There were bleeding was still ongoing at a time for cutoff for 2 participants for the Softy, since they couldn't control the hemorrhage, so these were non-survivors. Even though they were told where to place the tourniquet, good tourniquet placements was registered in only 60 to 75% of attempts by type, and then the detectors failed to register placement of tourniquet at all in 31 to 55% of types of attempts. The Softy system also did show a significant decrease in reading the manufacturer instructions. A lot of this has to do because it's literally pictures with 1 or 2 words, as opposed to the other 2, which has a lot more explanations. And if you have a minute to read, you're actually not going to read through it all. So of the 16 participants that had prior exposure to tourniquets, 100% of them were able to successfully stop the bleeding in a timely manner after reviewing instructions, compared to 62% of the people that were using it for the first time. So this is something to consider as well, whether even just having a little bit of exposure increases your chances of applying it successfully versus not. So basically, it went on to say that the conclusion was that untrained laypersons cannot reliably read an instructions quickly within 1 minute and then apply a tourniquet. This is also in a controlled setting, not in a chaotic setting where people are all.
You don't have blood, you don't have adrenaline.
You don't have adrenaline, you don't have anything like that.
I actually wonder if they might actually perform better because of all the adrenaline, because you're gonna really tie that tight.
Yeah.
This is sort of topical because of the fact that we've had like the Boston Marathon where people were putting on tourniquets. They're advocating for a lot of bleeding control kits in high concert arenas, sporting arenas, and what's the point if no one knows how to use them? One of the things is applying it properly, even in ideal situations, doesn't necessarily come naturally. Yeah. What I do with a lot of our providers is I'll take the ultrasound machine out, put the ultrasound probe right on the femoral artery, and be like, okay, tie as tight as you think you need to. And when they're just they're screaming in pain, and they're like, yeah, that's it. And it's like, nope, try one more. And it's just like.
And I think a lot of it has to do is majority that I've seen are the CAT tourniquets. CAT tourniquets in hospitals, and pre-hospital too. A lot of times, if people don't know how to use it, then a lot of times they don't realize that you have to strap it tight as possible before you even use the windlass. The windlass is the last resort, so I think a lot of people think that the windlass is what's going to tighten it, but no, it's just a strap
it needs to be tight to begin with, and then the windlass is that extra. And this is actually, there's multiple devices out there for tourniquets, and each one has a little bit of a tweak. I like the ones that have the pictures, because pictures are easy to remember. It's universal language. And that's also why, on the first day of fellowship, one of the things I did was I brought out my bag of tourniquets and be like, okay, choose one that you haven't used before and try and figure it out. And some of them, literally, you need to watch a YouTube video on how to apply it, and you still don't know how to do it. So that's that. A good tourniquet is going to be something that's thick enough that can actually be tight enough to stop bleeding. And a lot of the times on a thigh or something, I'll use 2 tourniquets. A lot of people, IFAC kits, where they have the tourniquet and all the bandaging and everything, and that's really for them. So when you come up to someone who's injured, you use their equipment on them, because that's what it's there for, because you don't want to deplete your supply. So having the bleeding control kits at these concert and events are great, but you need people who know how to use them. Yeah. And that's essentially what this article is saying.
Yeah.
You have anything to add?
No. And that's a big thanks. That's a big problem, or what do I say? That's a solution that is being tackled by the American College of Surgeons and the Committee of Trauma.
It's the Stop the Bleed campaign.
Yeah, it's the Stop the Bleed campaign, and they have a basics of bleeding control that's booklet meant specifically for the layman person and how they can help until providers come and provide assistance. But even in their booklet, they have the pictures and they have the tourniquet and they kind of give an explanation, but there's so many different tourniquets and it's different using each, so a lot of work to be done.
I mean, it's also that too, that the majority of times when mass shootings are actually studied as to what killed them, it's not extremity hemorrhage. It's it's all internal stuff that we can't stop. So really, stop the bleed. It's great for us feeling like we have to do something, that we can do something. But majority of the times, there's really nothing that we can do in these situations.
But in the event of an actual extremity hemorrhage,
Yeah, exactly.
the tourniquet makes a difference between life and death.
Yeah.
And usually, if you just tie it tight enough to stop the bleeding, that's great. I would tighten it to the point where you stop blood flow. I had a case where someone had amputated their leg off, and there were 2 tourniquets on before I got there, and it was great. I assessed the wound. There was no longer bleeding. Didn't touch it. I delivered whole blood, did a fast exam, got them to the trauma center, and the patient survived. So it makes a difference. If there were no tourniquets, he would have bled out to death.
But this was tourniquets applied by pre-hospital providers, not
Yes.
a layperson.
Sure. I believe it was a police officer and first aid responders. We just went over an hour. Do we have room for one more article?
Why don't we stop?
Okay. All right, so that's it for Journal Club today. We're actually meeting in 2 days at Trinitas at 1 p.m. If you're around, please stop by, and we'll see you then.